in his presentation about the African region, where he said that the responsibility for hepatitis patients, for hepatitis treatment, lies with the patients. And I would respectfully disagree with this. I think the responsibility lies with many actors, including first and foremost governments. But I was wondering, Danjuma, if you would care to comment on what role patients can play and what role you've seen them playing in Africa, and particularly Nigeria, noting the many competing health challenges in your part of the world. Thank you.
Yeah, thank you, Jeff. Now, let me just maybe clarify. I actually did mention that the responsibility lies with the patient, but not just with the patient. It needs collaboration across the board, but patients should also have a voice and a say on what affects them. So I need to just clarify that. Now, actually, what goes on is that I feel patients' role, like for example, in advocating for improved access to treatment, goes beyond just advocacy, but holding governments and all stakeholders, accountable to what they have committed to do, and using the human right approach towards advocacy. Like we mentioned, health issue is no more the privilege. Like for example, the SDG, the governments have owned up and signed up to improve the well-being and health of all citizens. So this is a commitment by the government. So patient groups need to collaborate with all stakeholders in advocating, projecting the voice of the patients, bringing up issues that really affects patients. For example, just while after my talk, I just received an email just about 3 minutes ago from an individual from my Hepatitis here asking for help. This person has been on tenofovir, liver tonic for so many years, asking for help that is going beyond his health. He needs assistance. What can I do to help him? I just got that email. We've been receiving tons of emails like that. So I think.
Okay, thank you. So you would appeal partly as patients from the human rights perspective, and I've also been hearing that patients and other advocates can really raise the economic arguments.
Indeed, I think, and I think that came out of the conversation and by other presenters. It's not that WHO didn't want to talk about data. It is for a very long period of time we didn't have good data. And yes, we talked about HCC and we talked about end-stage liver disease, etc., but not sufficiently about hepatitis. We still do have a lack of data, but from the data that we have, we can clearly make a case. And WHO has indeed started to speak very forcefully about hepatitis over the last few years already. I would really say 3-4 years ago. And now with the strategy, as I was trying to point out, with additional guidelines that we have been developing for hepatitis B, for hepatitis C, the latest update we are launching actually in the context of this conference, launching surveillance guidelines. We're also putting forward a modeling for countries to actually make their own national investment cases. I think we really will empower countries towards having better data, and obviously as WHO we will play the role to put this all together and hopefully make a compelling case.
Thank you very much for the question. There are so many hindrances. The problem is that we're swimming against a tide in many respects that's moving in the other direction. In the sense that, from a global health perspective, and of course that filters down to national governments, there is a tendency to move away from disease-specific approaches to a much more health system-orientated approach. So just at the time, in reference to the last question, that finally viral hepatitis is getting some priority, we're at a period where everyone's going, we need to integrate, we want to have much broader plans for tackling disease. Symptomatic of that, for example, is France, which really started with this kind of first action plan on viral hepatitis, with one for hepatitis C and then they included B, have just recently decided they're no longer going to have a viral hepatitis specific plan. They're going to incorporate it into a much broader plan. So that's one of the issues. Another of the issues is that the financing. We don't have the kind of commitment to viral hepatitis that led to the creation of the Global Fund, and we're not going to have it. And indeed, again, the kind of global health movement is much more now focused on the money coming from countries themselves than from external donors. So honestly, that's going to take a few years before countries really start increasing their health budgets to meet that, I think. And then the third issue in terms of global health and why we're pushing this large rock up a very steep hill is the focus away from communicable diseases onto non-communicable diseases. And I think it is very important that, as I said, we do need to think about this in terms of cancer prevention and sell it as such. So there are some very significant hindrances, and of course awareness generally is a critical issue. And it's complicated because we don't have a single message in viral hepatitis. We're actually technically talking about 5 hepatitides in the first place, with different modes of transmission, different types of disease. And so getting awareness messages across is really challenging. And what I think that means is that everybody in this room has to be doing something to advance the cause. Because it is such a challenge, we cannot sit back and think, that person at the end of the row, I'm sure they'll do something. It's really everybody. And unless we all push, and at a conference like this, we have a lot of clinicians and a lot of people from the individual national societies. In each country, they need to be pushing really hard. They need to be combining with the patient voice. As Danjuma said, that's absolutely critical to this. And really pushing, and unless we continue to shout, and truthfully, we don't shout very loud in global health as a community, even within countries. We really don't. We've got to get better at this. However, we are in this incredibly privileged position that we have almost all of the tools that we need for elimination. So in a way, it's particularly tragic if we don't make use of them. And that is about all of us doing our bit.
Dr. Contreras, please. Comment.
Yeah, that was exactly what I was going to say. I mean, I don't think that we have to wait until the World Health Organization does something. I think we already have enough data and enough tools to take the leadership. Somebody has to take the leadership in the country and get the patients, the patient advocacy, the industry, the societies, medical society, and all get together to convince the government. I mean, if we see Georgia, India, Egypt, they all are achieving what they have achieved because somebody convinced their government to put the money in. We need more data, but we already have enough data today that if we take leadership in our country, and as you said, and as I said in my Congress, we hope that when we leave this room, we all take this fight as ours and go to our country and try to move the ball forward to convince the government to put the money in hepatitis, and we're going to achieve much more than you ever thought.
So I have a question to really any of the panelists. I've just been wondering, with so much of a focus on hepatitis C treatment, and Charles, you mentioned the other types of hepatitis that we're trying to combat in the SDGs and in general in countries. If you see the immense focus on hepatitis C treatment as harming or helping efforts for hepatitis B and other kinds of hepatitis, I'm wondering how it plays out in different regions or even at national levels.
It has the potential to harm things, but at the same time, it's both. It's a disadvantage and an advantage. It's a disadvantage if we focus on treatment programs for hepatitis C, and we allow governments to think that that is an adequate response to viral hepatitis as a whole. And it is about advocating for comprehensive national plans. And if you happen to be somebody just interested in treatment of hepatitis C and you think, well, I don't really care in the short term, what I want is just money put into treatment now, I promise you, you'll find that's a really short-sighted approach. Because at the very least, unless there is prevention for hepatitis C, ministries of finance will lose patience with spending money on treatment if the prevalent pool is not shrinking and it's just being refilled. So viral hepatitis plans as a whole are absolutely critical to this. But it is also an advantage because it is very rare that you get a cure like this. In fact, it's unbelievably rare in terms of a virus, with such high cure rates, basically easy to take treatment. And so it is a way of focusing government's attention on viral hepatitis. It's like what department stores do with a kind of lost leader. You know, draw you in, and that's how we need to use it.
To give the example in connection with what you said, in Portugal, in fact, we were doing a plan, and when we get coverage from the state to pay the treatments, there was kind of a disinterest on the plan. So I think there can be this trend that if there's the money to pay for the treatments, the plan loses a little bit of the importance. And I completely agree that these are two different things and that the plans are very much important. Otherwise, we can treat patients, but there still is going on the epidemic. So
I think, to me, the simple solutions are the politicians and the public understand that it is blood-transmitted disease. I would request WHO and all of you to think, you have a World AIDS Day on December 1. You have a World Disability Day on December 3. You have World Hepatitis Day on July 28. If you make December 1 as World AIDS Day, maybe you can club December 2 as a World Hepatitis Day. It is easy for them to understand that yes, this is to be prevented. I know it is provocative, I know it may not be possible, but how do you focus that these can be piggybacked? What we are trying is to use the expertise of millions of workers across globe who are working on HIV, and we are using, like India has 1100 centers of national AIDS control. Now, let's say HIV has gone down. How do I use those people? And we are trying to convert the national AIDS control to hepatitis and AIDS control. So I think it is the synergy which might help in the political setting, and it might just give the people a clear message. So my thought is that we should club and make it simple, that this is what you can prevent and this is what you can treat. These are the people, this is our capacity. I think what we are doing is diverting the two and then trying to fish out this to make one goal. I think our goal is to prevent, our goal is to screen, our goal is to detect, and which are blood transfusion related disease. I don't know what the thoughts are, but this is the way in India we do. We have December 1 to December 7 is Hepatitis Awareness Day. We start from AIDS, but for 7 days in December. December 4th is our Hepatitis Day Awareness Day. Whole of Delhi and the regions around do it so that everyone knows this is the week. All the metros and everyone carry blood preventable diseases.
Yeah, I want to echo what Charles mentioned, and what other people have already said, that hepatitis doesn't get the attention of the health ministries or the WHO until very recently, largely because it's overshadowed by other infections which are on the decline, whereas hepatitis B hasn't declined as much. We cannot wait until we have perfect data. We never will have perfect data. I think we have enough data to say that this is a problem. This is a problem in every country. We haven't actually seen the decline that we would expect, and we should make it move up to the priority. As Charles mentioned, there has been rarely in the history that hepatitis gets so much attention globally because of the hepatitis C drugs. It's like a department store, draw people in, and then once they come in, you have to make sure that they actually understand the bigger picture and not just one thing. And we need to really have a very succinct message that this is the time to actually raise hepatitis to the top of the list and not just be a forgotten infection. And the liver cancer link is very important because there's so much attention on cancers, and not everyone in the public health field is aware of that important link. And it's even in the United States. That's the cancer with the most rapid increase.
I think now the worldwide, as the hepatitis becomes a global health problem, is a unique movement, I will say. Because, of course, the eliminate the hepatitis is not only the subject of the treatment. Yeah, it's very good that the last 4 or 5 years we have a great achievements in the treatment of hepatitis C, but we cannot eliminate hepatitis only based on the treatment approach. This is I will say, and I repeat this many times during my presentation, this is the new comprehensive public health approach, because that's without, the harm reduction, strong interventions, without safe blood interventions, without safe injections interventions, without awareness, without education of patients and the population, we cannot reach this. That's why the currently hepatitis C movement could be a driver of the new public health more development. This is one the topic what I'd like to underline. Then the second one, of course, we cannot, and this was underlined here, without the political commitment. Because without involvement of politicians and the strong political support, we cannot reach the elimination. And one of the good examples, today my country was presented here as an example, is that in audience we have a deputy minister now of Georgia who is a chair of the state commission, and the political commitment also is also the case that the politicians are quite strong involved in this subject and in this problem and in the hepatitis process. Without strong political will, and the big organizations like the WHO, CDC or others, international organizations, World Hepatitis Alliance should give more support from the politicians. And I think in this case, sometimes my country could be a case study. Thank you.
Yeah, I would like to add my voice to the issue about Hep C and Hep B, because from Africa, we have the highest burden, especially in sub-Saharan Africa. The greatest challenge we face is with hepatitis B. And each time I attend forums like these, or pharmaceutical companies, most of the research is into Hep C, but very little into Hep B. And it's really a great concern to patients and patient groups from countries or regions where hepatitis B is most prevalent. But nonetheless, it's good enough that there are hopes on the cure for Hep C, which will actually drive the momentum forward in trying to draw attention to Hep B. Now, I'd like to add the issue of clinicians and patients working together. It's great that EASL really brought this forward, and I want to really advocate to clinicians to not see patients as just subjects, but as partners, that together we can work this towards, really achieve this goal of elimination of hepatitis, and advocate to politicians and policymakers to really come up with plans and interventions to address this hepatitis pandemic.
3 very quick points. Coming back to why we actually put forward global targets, it is a way of actually publicly having governments to commit. In May, when 193 member states of WHO, basically 193 ministers of health come, they will hopefully sign on to this strategy on these global targets. They will have to go back and say, what does it mean in my country? And that's where these national investment cases, this national data gathering exercise needs to come in to say, well, this is what it means in terms of numbers, in terms of budget that I need. So that's why I think it is a tool not only for ministers or the UN, it is really also a tool for civil society to say, hey, Minister, you just signed off on these targets. What are we doing in country XYZ in my country? So that's one of the things that I really think we need to highlight. B versus C. I agree, there's been so much attention on C, but I think it is also an opportunity for the forgotten B, because we really need to push towards comprehensive national plans where C and B, and if other hepatitis exist in a given country, are also addressed. And the problem is that the attention has been very much on HIV, TB, malaria, because the funding has to be going there. You know, there is a global fund, etc., etc. It is very unlikely, I believe personally, that we will see something like a big global fund for hepatitis. So countries will have to make financial commitments themselves, particularly the middle-income countries, to say, this is how we're going to pay for it, and this is the money, this is how we front-load the resources over the next few years.
I think the real challenge we are going to face is how to convince governments to pay for prevention, not for treatment. With the new DAAs, the efficacy of the SVRs more than 90%, with the presence of generics, which are relatively cheap, it will be relatively easier to convince governments to pay for the treatment. But the problem, the real problem and challenge is to convince politicians and governments to pay for prevention of disease. And this is so true in HCV, where you can get the patient reinfected after cure. So we have to think how to convince our governments, how to convince the politicians to fix a budget or to pay for the prevention of disease. This is the coming challenge in hepatitis. We do not implement mass screening for hepatitis C. What we do is we have already announced that anybody who knows that he is HCV infected would apply online for treatment. And this is how we got the patients registered. The coming problem is how to get new patients diagnosed. So the plan is, the first thing is to screen families of patients who are already known to have HCV, to screen those persons pre-employment and those who get drafted in the army, and this is already being done. So this is the way we're going to screen the patients. But the most important thing we are applying now is to use the treatment centers themselves, the 51 treatment centers dispersed all over Egypt, to screen patients, to screen relatives, families of patients who already have HCV. This is the first step. Pre-employment, the next, and those who are drafted to the army.
Can I make a comment on this? Screening is a crucial point, of course, one of the hindrances we are facing. Certainly one thing has to be said very clearly. We cannot keep using a risk-based screening strategy. We should forget about that, because it doesn't work. We've been doing that for 30 years. It doesn't work, very simply. So we have to change the strategy. If you want to find all those patients who are not aware of being infected, we must completely change the attitude.
The problem in reaching this population is the stigmatization. In order to reach this population, for example, in Egypt, only 20% of those infected with HCV know that they have HCV, only 20%. So if you're going to call for mass screening, you have to prevent stigmatization. You can't just ask for the whole population to be screened for HCV and then tell him, okay, you are HCV positive, you won't be employed, or you won't be drafted in the army, or you won't get any privileges. So first step, if you want to do mass screening of the population, is to prevent stigmatization. And then go ahead and call for mass screening. Otherwise, the persons you're calling for will not go for screening, because they know that this is stigmatic.
I'd like to make a comment on the screening. I think the classic risk factors are not necessarily applicable to every country. I mean, I bet that the healthcare-related transmission is probably greater than in one place to the others. And in Latin America, that is a significant risk factor. In fact, it might be the most important factor nowadays because blood transfusion has become very safe. And I'm also, even though I think we need to do the work with the age-related factor, I'm not sure that in countries where IV drug abuse was not a problem or is not a problem if that is as significant factor as like in the United States with the baby boomer where maybe the reason was because during those age or during those days IV drug was very popular. So I think the bottom line with screening is that every country should do their own work to try to find out which are the risk factors and to see if there is a specific age where that you can focus on narrowing your attention.
So what you're saying is that in some countries where improvement in hygienic condition means that children are not getting hepatitis A, they get infected at a later age and they actually get sicker, which is really the case in the United States. So hepatitis A vaccination is now recommended as childhood vaccination because the only way is to make sure we can't just assume that, okay, now you're planning a trip to an exotic country, you get vaccinated. Just get all the children vaccinated so that you don't need to worry about where they're going.
Yeah, I actually agree with that. Unfortunately, like in Latin America, only Panama has actually endorsed universal vaccination for hepatitis A. But that will be the easiest way and probably the cheapest way to deal with that.